Today is September 17th, 2010. My name is Tony Kovner. I'm a professor at NYU, the Wagner School, and I'll be interviewing Paul Elwood Jr. Paul Elwood went to Stanford University for both college and medical school. He did his pediatric internship at the University of Minnesota. After directing inpatient services for the Sister Elizabeth Kenny Institute, he headed its successor organization, the American Rehabilitation Foundation. Dr. Elwood was then clinical professor of pediatrics, neurology, and physical medicine and rehabilitation at the University of Minnesota. Subsequently, he became executive director of Interstudy, the health policy research organization that succeeded the American Rehabilitation Foundation. In 1992, he became founder and president of the Jackson Hole Group. A still unfulfilled objective of Paul Elwood's has been to make healthcare organizations and other human services publicly accountable to consumers for their impact on patients or members' health, function, and well-being.
After the HMO Act passed in 1972, we expected that HMOs would spring up all over quickly. They didn't. And I'm going to have to check these dates, but then it was, I guess, almost 20 years later before we had any number of HMOs. And at the time we had maybe 1 million people in HMOs and 14 prepaid group practices, classic HMOs, the kind I preferred. 5 years later, there were 81 million people in HMOs, and virtually all of them were in for-profit plans. So the big idea of HMOs was perverted by managed care in these large organizations. Now, what I'm trying to say is that when you go to politically reform the health system, like the Obama administration is trying to do now, we're not going to know the results of that for 20 years. By that time, you've changed presidents several times. You've changed the leadership within the government of healthcare several times. And so we need some way of managing this series of reforms over an extended period. That you needed some way to follow this industry and sustain the reforms, rather than, as happened with HMOs, where it went from being an ideal form of healthcare to managed care, which became an ideal form of risk selection.
Let's pick that
and
up.
in the meantime, all the people who had anything to do with reforming it in the 70s
We're gone.
were gone. After the Health Planning Act was passed, Phil Lee chose Paul Sanazaro to run it. Paul, in turn, convened a small group of individuals who had different points of view to advise him and to advise the Secretary of HHS, or HEW, I guess it was called then. That group consisted of Marty Feldstein and Rosemary Stevens, Kerr White, these giants in medical thinking and health policy thinking. And from them, I learned a great deal about where health policy was going, how it's made, so forth. In the meantime, our little medical ecology group had begun to work on things other than health. It had begun to work on welfare. And we had a contact in welfare by the name of Tom Joe. Tom was a blind Korean man who was an expert on what they called in California, where Tom was from, federal buck maximizing. How to classify people on welfare so you get the maximum federal match. And Tom and my little, our little group of medical ecologists became acquainted. And I met Tom then on an airplane going from Minneapolis back to Washington. Tom and I got talking about health policy and how it related to his work in welfare policy. And Tom said, "You've got to meet my boss." And I said, "Who's your boss?" And he says, "His name is Jack Veneman." He said, "I met him when he was an assemblyman in California, and he's now undersecretary of HEW." So Tom arranged for me to share some of my ideas on healthcare with his boss. We met in a hotel room in Washington, DuPont Plaza, with Veneman, Tom Joe, and a doctor from Philadelphia by the name of Georges. Georges was an African-American public health kind of physician who I subsequently learned was at this meeting to make sure that Elwood was being honest. The meeting began, the background on why Veneman might want to meet with anybody about healthcare was that Nixon had realized that Kennedy was coming up with some health policy ideas, really his first national health insurance scheme, that were going to upstage the administration. This is Teddy Kennedy, not his brother. So they had to have a health policy, and they didn't have one. And Veneman was charged with coming up with one, and they weren't getting anywhere. So Veneman's opening line was, "We understand you've been thinking about health policy. What are your ideas?" And so we spelled out kind of the idea of a series of organizations competing on the basis of price and quality, pretty much the prepaid group practice model. I definitely preferred group practice at the time. Went through it all, and Jack Veneman said, "Hey, these sound like good ideas. I think that this is what we ought to do." We were joined then by Lou Butler, who took the conversation a little longer. The conversation went into the night. But by the end of the night, we'd pretty well spelled out the entire HMO policy. Now, there were a couple of points of disagreement in the meeting. One was I preferred group practice as the model. Lou Butler said, "Look, hey, we're going to be relying on market forces here and people making choices. Why don't we let the market decide what is the ideal organizational arrangement?" I acceded to that, but after the Mayo Clinic experience and so forth, I was really committed to group practice. A second issue was profit or not-for-profit. Again, I preferred not-for-profit, But the argument was made, we've been observing nursing homes and the need for more of them. And while the church homes and so forth are very good, they're not expanding at the same rate as the private homes. And if we want this to really affect the whole health system, we're going to have to allow for-profit arrangements. The third issue that came up was the question of measurement of results. And here was another chance to introduce the notion of measuring outcomes as a means of determining who was effective and of giving consumers information about where to go for care. I don't believe that consumers can differentiate well once they're sick. They have no choices. But at the time they buy insurance, they can. And it seemed to me that it would be desirable to have outcome information. Also, the issue of skimping even arrived at that point. And again, I tried to make the point that if there's skimping going on, we've got to measure it. We've got to determine whether or not people are being selected on the basis of being well and whether the providers are providing inadequate, cheap care in order to compete in this marketplace. I lost on that one right from the outset. In the meantime, Kennedy's bill, which our people were working on too, with Phil Caper, did contain a health outcomes provision that was perfect. If we could apply it today, it would have been just fine. I wish I'd seen it in the Obama bill. But at any rate, so there was this tension, but nevertheless, what came out of that meeting was essentially the whole HMO policy, except that we didn't know how to do any arrangement other than group practice. And they sent me off to meet with the AMA, which objected to group practice, to find out if there are any other ways. And I met with the head of the AMA who said, well, you know, we've got something going on in Stockton with the medical society there that might work. And what that medical society was doing, they were trying to keep Kaiser out of town. And so they had set up their own HMO-like entity where the medical society was at risk to provide services on a prepaid basis. So it's sort of a medical society insurance company. I dubbed it the IPA, Independent Practice Association. Brought that idea back to the Butler and Veneman. They thought that was fine. That was a way to placate the AMA and gave us another model. But it was so exciting to be having these ideas for all this time and then finding these big shots ready to buy them and take it to the President of the United States. Well, it wasn't all there was. The original idea was to incorporate this in Medicare. It's called Part C. Jack Veneman met with Wilbur Mills at a barbecue. The two of them talked it over, Republican and Democrat. Wilbur said, fine. And so Tom Joe named it Part C, and the Ways and Means Committee was meeting at the time on Medicare. At the end of a meeting, Wilbur Mills had forgotten to bring up Part C. Veneman stood up at the meeting and said, you know, Mr. Congressman, we have this additional idea that you and I talked over called Part C, and he described the HMO idea. And in 15 minutes, the committee adopted it. However, when the idea reached the Senate Finance Committee, which also has to act on Medicare legislation. They killed it. Individual by the name of Jay Constantine didn't like the idea at all and was already working with the AMA on the peer review idea. So it died. So then it had to become a private sector program instead of a public sector program. And it took us, it took them 3 years to, or 2 years, to finally work it through the Congress. The HMO movement accomplished one other thing that's not very widely known. It actually controlled inflation. There was a 6 or 8 year period where healthcare costs were not rising any more rapidly than the rest of the economy. Now, the economy was healthy at the time, and so they could grow. But more important, during that time, a real transformation in the leadership of insurance in the country took place. The leaders who had been heading largely mutual and not-for-profit insurance companies, the Prudential, the Equitable, New York, the Met, were replaced by people with a profit and an actuarial mindset. And the name of the game became risk selection. And at the same time, doctors had discovered a way, or the AMA in particular, a way to shoot down the HMO idea, and that was to plant in the minds of patients that they were being underserved, that they should have been allowed to be in the hospital and so forth. So the skimping notion took over. And it was so the HMO idea faded, except the multi-specialty group practice, not-for-profit plans, the Kaisers and so forth. My father said something to me about when he was in his 80s and working in a community health center in the toughest part of Oakland. He said, "Son, I'm ashamed of our profession." And in some ways I am too. I think that the whole thing has been commercialized, if you will, distorted by money. And the issue is how do you get away from that? And I suppose the education of citizens and the education of providers might help. But I think we learned from the HMO experience that if you're going to attempt to transform an industry of this scale, the largest industry in the world, incidentally, the American health system, it's going to require a huge cultural shift, that consumers are going to have to be much more in on what's going on and treated in an entirely different way. They're going to have to know whether or not their doctor is doing a good job. And they have to be sought out routinely as to what the impact of healthcare has been on them. I think the only way to do that is to create some mechanism to measure the effectiveness of individual physicians and healthcare organizations to improve people's health. the key notions here are that healthcare takes 20 to 30 years to change. The political environment during that period of time is going to change. The technology of healthcare is going to change. The attitude of doctors and hospitals and patients is going to change. So you have to have some sort of institutional mechanism that measures the effectiveness of this industry in producing health. And so if it's going to last 20 years, it's got to be isolated, or 30 years or 50 years. It has to be isolated from the politics as much as it can be. And our best metaphor is the Federal Reserve System. But if you're going to invent a new Federal Reserve System, the Federal Reserve manipulates interest rates and that sort of thing. What do you manipulate in healthcare? Well, I think you attempt to manipulate results, outcomes. Just the outcome that the Federal Reserve System is seeking is controlling inflation and keeping the economy going. They've had to deal with a whole variety of good and bad banking mechanisms, if you will, but they've always had the same endpoint. How is the economy performing? And is it growing, and is inflation under control? So we need a similar thing in healthcare. Well, what is it for? It's to keep people healthy and to get them healthy. And therefore, the measure, the analogy to inflation, is health outcomes. And so you have to create an agency to collect health outcome data, isolate it from the rest of the government and the rest of the system, and then use its findings to determine what it is that's worth spending public or private money on for healthcare, and use it at the same time to change the value system here, to make doctors something other than isolated professionals, to people who are supposed to produce health, and where you measure whether or not they're doing it. Now, how do you manipulate the economy? There's only one way you can do it. If a treatment or diagnostic procedure or whatever is not effective in producing health, you don't pay for it. Now, sure, let people go ahead and pay for it, but the government, which literally buys all of the health in the country virtually, because the tax exclusion for employers and Medicare and Medicaid are it. So I would say that Congress should do as they do now, say to the Federal Reserve or to the Health Reserve Company or whatever you want to call it. Our budget, we're running over budget. What outcomes can we buy with what we've got? The Jackson Hole Group was formed at first to further study and promote the HMO idea, to identify what was going wrong, what was going right, what should be added to it. And we began by inviting just an eclectic group of citizens and leaders in healthcare out here to Wyoming.
How many board members?
Typically, at first the meetings were about 10 people, and they never exceeded 20. They were highly organized affairs. They seemed very informal. We began with an opening ceremony where you would make Senator Kerry walk in carrying a rifle, and some governor bringing in the American flag, and somebody else a British flag to represent the National Health Service in Great Britain. But they were very, very serious meetings. The key invitees were given an assignment to address based on their experience, what they knew about. And they took these assignments very seriously. It was very interesting. You'd see the president of an insurance company having to speak about some of their experience. And here you've got the presidents of a bunch of other insurance companies and all sorts of big shots in healthcare are there to listen. And they were very serious about these presentations. And then following their presentation, there would be a discussion of some kind. And the group always had sort of a theme that it was pursuing during the course of any one meeting, and maybe there would be 5 or 6 presentations each time. But the initial emphasis was on building the HMO movement. With the passage of time, though, the HMO movement had taken off, was beginning to go in directions we weren't happy with. And so we began shifting the focus of the thing towards the next generation of health policy, the next generation of healthcare. And a couple other points about the meeting. We always broke in the middle of the day so that they could go off and go rafting or snowshoeing or something. And so the group became pretty cohesive during the course of any one meeting. But they also knew now that they were working on some larger, longer range objective. They met a total of, I think, about 30 times. Always a different cast of characters. Certain people ran through most of the meetings, Alan Entover, for example, but this emphasis shifted to devising the next stage of health policy, going after some of the things that had been left out, like malpractice, and continuing to push the idea of outcomes measurement and how it might be done, and so forth. We never allowed the media to attend the things, but we did allow an editor who was an economist of the New York Times to attend. The journalist from the New York Times contacted us in just prior to the Clinton administration. He said that in the New Hampshire primaries, that one of the candidates, Bob Kerry, had a health plan. Kerry, incidentally, had been to Jackson Hole Group meetings, but another one didn't, a governor of Arkansas by the name of Bill Clinton. And would we send the managed competition ideas that had to come out of the Jackson Hole Group meetings to an individual by the name of Ira Magaziner, who was working for Bill Clinton. All of a sudden, we noticed that the rhetoric on healthcare of the Clinton administration was the outcomes management rhetoric of the Jackson Hole Group. When Clinton was ultimately elected and Mrs. Clinton was designated to be responsible for healthcare, I wrote a letter, or we wrote a letter, several of us signed it, to the new president, suggesting our eagerness to help. And this letter was signed by who's who in healthcare in the United States, really. I got back a form postcard that said, "The president always appreciates Americans who are interested in the betterment of the country. Thank you very much." Ira wouldn't see us. We literally couldn't penetrate the policy-making process there. Was totally different than, for example, the Nixon experience, or even the experience we had with Carter and a number of other presidential administrations. And that situation persisted. Finally, it was possible to meet briefly and perfunctorily with Mrs. Clinton. But we were the enemy. We were the industry. In the meantime, we began meeting with the Senate Finance Committee, which at this point was headed by Moynihan. Moynihan had become a friend of mine because my son was responsible for welfare reform under the Clinton administration, and that's what Pat was all about. So the Senate Finance Committee began devising an alternative proposal that was really rather good. But it didn't look like it had much chance of going anywhere. Again, it was bipartisan. John Chafee was the chairman. It was a Democrat committee. So they prepared an alternative. Then I got a call from my son, who was at that time Assistant Secretary for Planning and Evaluation in the Clinton administration. They'd already done welfare reform. And he said, Mrs. Clinton wants to meet with you. And this is the first time she'd ever even reached out to us or listened to anything our group had to say. And so I went to the meeting, which was in one of the, it wasn't in the White House, it was in one of the office buildings over in the Senate, I think. And David, my son, was there, and another David Gergen, was there, and Mrs. Clinton. The message was from them, somehow we want to make a deal with the Senate Finance Committee people. And I asked, how familiar are you with the Oslo negotiations over Israel? You're that far apart. And Mrs. Clinton said, well, we know a lot about that and are very interested in it. I'm sure now she's even more interested in it. And what she said was that there was a go-between the two sides that helped to coalesce things. And I was asked to go meet with Chafee about the possibility of some sort of a arrangement between the two. I went to John's office, John Chafee's office, and he was busy on television he finally came out of his office and said, Paul, geez, I'm late to catch a plane to Rhode Island. And won't you come along in the car with me? Well, I thought, geez, we're gonna have quite a bit of time with the senator to make our pitch for Mrs. Clinton. And we got in front of nobody's ever heard this story before. We got in front of the Capitol building. You know, that underpass is located in front of the Capitol there on the highway over to the airport. We're in that underpass, and all of a sudden, all kinds of red lights went on, and we got stopped. I thought, well, fine, there's more time to talk to Senator Chafee about these ideas. And finally, Chafee put down the window, and there was a cop standing there. And by that time, he'd missed his plane. And Chafee says to the cop, how come we're stopped? And the cop says, presidential motorcade. And with that, Chafee swore, and he said, you tell that woman to come and see me herself. The next day I got a call from Air Force, whatever her designated airport was, as to what happened. I described it to her, or to her staff, and she never followed through. And that was literally the end of the Clinton health plan. The two sides never met. The Jackson Hole Group then went on, and with the Jackson Hole Group, personally, I had one missing serious objective, and that was outcomes management, measuring and making available information about healthcare to consumers and providers, and then having the government pay for what works. We had a series of meetings where we worked around this idea and other ones. Finally, we came to a meeting where the group was going to, for the first time, vote on something, and that was whether or not the insurance companies would push outcomes management, health care accountability. Their spokesman was Bill Roper, who had headed CMS, had headed CDC, great person in the health system. And at the time, he was working for the Prudential. And he announced that the insurance companies were not prepared to go along with outcomes accountability. It was the only time at a Jackson Hole meeting where I think I lost my cool and shouted at him a little bit. But we had some subsequent meetings. The next meeting, the group decided, well, we have to create something that could push this idea of accountability in healthcare. And so the Foundation for Accountability, called FACT, headed by David Lansky, was formed at that point. And they went on with the idea of trying to convince, especially provider groups, to be accountable. I don't know how long FACT lasted, but several years. David was, I thought, a great leader, had a wonderful staff. We couldn't crack it. We were trying to crack the whole notion behind professionalism. I'd have to be very candid with you and say that we've had wonderful opportunities to shape the health system, but the ideas have not caught fire. On the other hand, if you read between the lines in the Obama legislation, despite the chaotic way in which it's developed, the notion of outcomes is there. There are all kinds of modest devices for creating multi-specialty groups. The idea of lumping together hospital payments, putting them jointly at risk. So then there's this accountable health plan idea. These are all the same old ideas. Now, Don Berwick and others who are responsible for trying to implement that are going to face this problem that ultimately undermine the HMO idea, and that is too many possibilities. Because in the case of the HMO, the bad possibilities for profit and IPAs killed it. So that they're always tempted to grab onto the idea that you think will expand the whole thing, but the bad guys can win too. And that's what I'm concerned about with the magnitude of this legislation, that perverse influences may be more powerful than others. Now, it's so broad, and regs have to be written for so many things. I think my advice would be to Don to pick out the few that you really like and work on them, and let the lobbyists clobber the others. If you think that anyone else is going to have the opportunities that I had as an outsider or insider to shape health policy, you realize there were no competing ideas, no competing individuals. There's so many competing voices down there now. The lobbyists are far more powerful. We didn't have to contend with any health lobbyists, none, other than the AMA. Now it's an institution that's as big as the government or bigger. So I think it would be hard for any individual to have the same, or group of individuals to have the same opportunities that I had.